Thank you. Thank you not only for introducing me, but sitting through the talk. And thank the audience in advance for being here at this late hour of the day. See, I think what I'm going to be discussing is not something new. You have all been exposed to this in the last maybe 10 years and more so in the last 3-4 years. I'm just going to give you a snapshot of what has really happened over the last 20-25 years in terms of how our focus from infectious disease, tuberculosis, cardiovascular disease has now become non-communicable disease, including cardiovascular disease, diabetes, cancer. So there has been a drastic change. We are all living longer. And in that process, we're seeing more complications of conditions like diabetes. I was a student of diabetes in the 80s. And I think in the last 40 years, we've had so many new medications, but whether our patients are doing better, I'm not saying whether they're living longer, but whether they're doing better. So let us look at two prototype patients, which you would be seeing in your practice quite regularly. So this is a 45-year-old young patient, Dr. Brijmohan, for the record, 65 is middle age and not elderly. That's what WHO has said. So we are, at least I am still middle age. So diabetic for last 1 year, hypertensive since 7 years, dyslipidemia 10 years, family history of myocardial infarction, moderately active lifestyle, occasional smoking, the standard metformin, rosuvastatin, telmisartan on his treatment. BMI is 28, waist circumference is 102 centimeters, blood pressure is okay, ankle break-in index is a little on the lower side. So you can see from now that his A1C is 8.1%, insulin fasting is on the higher side. Lipids, you can see LDL is 92, so if you take 100 as the target, then he's below target, but if you take 70 as the cutoff, then he still needs some more aggressive management of his lipids. GFR is 80. Let us say for the sake of argument that the USCR is normal. On the other hand, if you take a 58-year-old patient who's got similar medical history but hypertensive for a longer period, dyslipidemia for 15 years, on metformin, atorvastatin, telmisartan, amlodipine, and hydrochlorothiazide. BMI 26, blood pressure 130/80, A1C 8.2%. Lipids look reasonably good, but his GFR has now come to 46. Creat is 1.7. So one of the take-home messages at this stage is do not rely on serum creatinine to decide where the patient stands. Simple formula, get the eGFR from your smartphone and then talk to the patient whether they're in stage 1, 2, 3, 4. So the albumin creatinine ratio is 180, which is something we recommend that you should do it at least once in a year. Treadmill test positive, echo shows grade 2 diastolic dysfunction. So we've heard this time and again that when you're looking at type 2 diabetes with declining renal function, it's not the renal function which will kill them, it's the cardiovascular disease that you're really worried about. The ADA, EASD, IDF, RSSDI all have stressed on the fact that along with control of hyperglycemia in patients who are having underlying heart disease, ASCVD, heart failure, or a declining renal function, you have to use SGLT2 inhibitors and or GLP1 receptor agonists. There's absolutely no doubt about it. And anyone who's not following these guidances, even if you don't look at it as guidelines, is doing a great injustice to their patients and to their practice. So this is one important point. And we could have been discussing this 3 years earlier, but today there is absolutely no two views about it. We are all familiar with the octet, and we have gone on to the dirty dozen various factors which keep causing type 2 diabetes. The reason I've shown you this slide here is to tell you that one single drug, whether we are talking of orals, we are talking of insulin, we are talking GLP1 receptor agonists, is very difficult to control because type 2 diabetes by itself is a progressive disorder. So when we think about therapy, you could go 1, 2, 3, 4. or you could at least go 2, if not 3 at the beginning. And the focus of my talk is going to be on EMPA and LINA combination. So EMPA, I think those who heard Dr. Unni, he's very vividly described the good points of empagliflozin in terms of glycemic control, then the hepatic fat that he was talking about, reduction in MACE, one of the only drugs which has actually shown reduction in CV death. Two people could argue whether the patient is in failure or not, but there is no argument on whether the patient is alive or dead. So empagliflozin has shown reduction in CV death. And then when it comes to heart failure, I think as a class effect, all SGLT2 inhibitors reduce the hospitalization for heart failure. And you're all aware that it's an important pillar of management of heart failure, whether it is reduced ejection fraction, minimally reduced ejection fraction, or preserved ejection fraction. Probably the only class of drugs which works with HFpEF is SGLT2 inhibitors. And in addition, when it comes to kidney production, the nephrologists initially had their doubts, but they're excited about how SGLT2 inhibitors help protect the kidney and those who have a declining function to prevent the further decline, and there is enough data to even show that it can reverse the declining kidney function. Linagliptin came late on the stage, but it got labeled as a kidney-friendly DPP4 inhibitor, and over the years has shown that it's about as good or as potent as the other DPP4 inhibitors. The beauty about DPP4 inhibitors as a class is they may not be as strong as sulfonylurea or as cardioprotective as the SGLT2 inhibitors. But as like one of my friends used to say in the beginning, that you can prescribe a DPP4 inhibitor over the telephone and you don't have to have the patient sitting in front of you and giving you a whole list of do's and don'ts. So when you combine empagliflozin and linagliptin, you can see that it takes care of nearly all the defects that were shown in the earlier ominous octet, and that gives it a couple of brownie points. Multiple studies have looked at the outcomes, whether you're looking at EMPA-LINA 10/5, EMPA-LINA 25/5, EMPA alone 10, 25, and LINA 5. And the fact remains that whether you're taking the combination 10/5 or 25/5, they have better outcomes and a stable A1C over at least, this is 52 weeks, but this goes on to 104 weeks also. We have now started talking not only of A1Cs, but we're also talking of time in range. And as you can see in this study, from placebo to empagliflozin 10 milligrams, 25 milligrams, the time in range improves, and it starts from day 1, and by day 28, 4 weeks, there's a big difference. I remember years ago we used to say aggressive management, intensive control, and the bottom line used to be risk of hypoglycemia and risk of weight gain. So we know that empagliflozin and DPP4 inhibitors run a less risk of getting hypoglycemic in a patient. And the beauty is that there is some amount of weight loss against weight gain which you would see when the patient is well controlled. So it may not look big as compared to the GLP1 receptor agonists that we keep hearing about, but a 4, 5, 6% weight gain over the period of few weeks is significant. Dr. Unni did speak about the ELIFT study from Delhi, and one of the short, sweet, successful studies of reversing fatty liver in our type 2 diabetic patients. Do I really need to talk more about EMPA-REG? I'm sure, and I see some of my seniors who would like to see me off the stage fast. But give me another 5-7 minutes and I'll be done. So, like I said, one of the first CV outcome which didn't talk about non-inferiority or just being equal to placebo. They actually were superior to placebo. And as I said, the first studies where they showed that there was reduction of CV death in addition to reduction of 3-point MACE. And the subgroup of the Asian patients, if you can see, as compared to 38% reduction with the total population, with the Asian population, it was about 56% relative risk reduction. So Major adverse events, cardiac vascular, myocardial infarction, coronary revascularization, significantly reduced as a part of the EMPA-REG outcome. And although not a direct primary event, but the worsening of nephropathy was slowed down, progression to macroalbuminuria was slowed down, the doubling of serum creatinine and the risk of renal death was significantly slowed down. In addition, those patients who already had developed nephropathy, you can see that at least 43% reversal of microalbuminuria into normal albuminuria and macro into micro, 82% risk reduction. So that was something in the beginning, which now has been confirmed by multiple other studies. In addition, the fringe benefits, you can say, or value-added benefits with empagliflozin was improvement in hemoglobin levels. We now know the importance of treating hemoglobin even in cardiac failure, not general health, but with cardiac failure. And there was some amount of reduction in uric acid. So as I mentioned with EMPA-REG, that was not the primary focus, but in EMPA-Kidney, the primary focus was looking at what happened to the kidney disease. So these patients, again, 45% risk reduction in progression to CKD, 44% risk reduction in terms of reversal of the disease. So that gave the confidence not only to cardiologists and now nephrologists. And this use of empagliflozin has progressed from diabetic patients to non-diabetic patients. A real-world study from insurance data, 145,000 odd patients, as compared to the use of GLP1 receptor agonist. The use of SGLT2 inhibitors and specifically empagliflozin reduced the risk of myocardial infarction and stroke to the same extent as seen with GLP1 receptor agonists. But when you look at CV death, hospitalization for heart failure and end-stage kidney disease, there was a slight benefit in favor of empagliflozin. Just a couple of slides, not to be unfair to linagliptin. You know what happened with the saxatimi. We started off on the wrong foot and we got worried about increased risk of hospitalization for heart failure. Poor saxagliptin never came out of it, although real-world studies showed that it was not true. But with Examine, TCOS, and then Carmelina, the issue about heart toxicity or issues of heart failure were set to rest. These drugs have been shown to be neutral in terms of 3-point MACE reduction, and leave aside that little mark on saxagliptin, everything else seems to be quite normal. And Carmelina sort of again sealed the point in favor of linagliptin when it came to the renal dysfunction, when it came to progression to micro and macroalbuminuria. And the most important thing, as you see at the bottom, is albuminuria reversal, which was seen with linagliptin. So I'm going to conclude my talk by telling you that diabetes is a complex metabolic disorder. It's got a progressive nature. Multiple defects have been described in the pathogenesis of type 2 diabetes, and you do not expect one single drug to take care of all these pathogenetic defects. So combination therapy is here to stay, whether you use dual or triple combination. Linagliptin with empagliflozin is a wonderful combination in terms of efficacy, in terms of safety, and as the various guidances tell us, in the presence of ASCVD, in the presence of heart failure, and in the presence of declining renal function, SGLT2 inhibitors without GLP1 receptor agonists are here to stay. Thank you very much for your patient hearing.